Welcome to everyone watching. My name is Laura-Rose, my pronouns are she, her, and I'm founder of the organisation LGBT Mummies Proud Foundations. I'm delighted to be talking to you today in partnership with the wonderful group TFP Fertility, and I am joined by Clinical Director Chantelle Simonis. Hi Chantelle, how are you?
Good morning, Laura. Lovely to meet you and great to be here.
Thank you so much for coming and sharing your expertise. So we're going to be talking about explaining fertility options for LGBTQIA plus families and what that looks like and the different options that are available for people. So Chantelle, to start off, can we talk firstly about one of the less invasive options for people? I'm going to talk about the definition and explanation of what intrauterine insemination is, IUI. So if you could explain that for all our viewers, that would
Sure.
be amazing.
Okay, so I think, I'll use the shortened version, which is IUI, as you've said, because that's what most people call it. It's really important to understand, though, that IUI isn't appropriate for everyone who comes through for treatment. And so we do need to do an assessment first to make sure that the partner that is going to be having the treatment has actually got open tubes, because you don't want to waste time doing IUI treatment if the tubes are not working. So it's a full physical assessment first, and then also making sure that the couple are sure that IUI is the route that's appropriate for them, because some couples, when we start to talk to them, have thought about IUI, but when we talk about shared motherhood later on, they say, well, actually, that might be something I prefer. So you're quite right, IUI is a simpler form of treatment. It involves the partner who's having the treatment undergoing stimulation to make sure that eggs grow. It involves some scans. And then once we're happy that the eggs have grown or the follicles have grown to the right size, we can trigger ovulation and plan to put a sample of sperm inside the womb, usually 24 hours later. It is simple in the sense that it doesn't require an egg recovery like full IVF does, but it does still require visits to the clinic. So you need to be scanned, usually on day 8 or 10 of the cycle, sometimes 2 or 3 scans before the eggs are ready. And it requires, obviously, the insemination procedure.
Oh, thank you so much. And can you talk a little bit about success rates of IUI, Chantal, and just explain that to people so that they have that understanding?
Sure. So the important thing to remember with IUI is we're approximating what would be happening naturally. So each month, the chance of a woman conceiving, if she has a good sample of sperm that is meeting the egg, is probably no more than about 15% in a woman under the age of 35. So IUI is not going to dramatically increase those odds. It's going to help the sample of sperm being closer to the egg, make sure the timing is correct for all of that, but we don't know that the egg and the sperm are meeting. So success rates generally for those under 35 are going to be about 10 to 15% per cycle. I tend to recommend that people over 35 don't tend to do IUI. And certainly over the age of 40, I would say success rates are under 5%. And
Mhm.
you've got to then weigh up, is the physical aspect of it, the emotional aspect, not to mention the cost of going through treatment, worth a success rate of only about 5% if you're
Yeah.
over 40.
Yeah. And what are the advantages so that people can understand why would it be an option? Why would it be a good option?
I think the important thing for most couples who choose IUI is that they want to be as close to a natural conception as possible without lots of intervention in a clinic. So it's the natural route, really.
Mm.
What's important, though, is not to think, well, it's cheaper, and so that is the right thing to do, because doing 3 cycles of IUI that are unsuccessful and then having to move on to IVF can end up being very costly. But we don't have a crystal ball and we don't know straight away who's going
Yeah.
to fall pregnant on their first cycle. I think the other thing, and a lot of my patients say to me, we haven't tried to get pregnant before, so why
Mm.
should we go straight to a really high-tech IVF situation when actually we want to try a more natural route?
And again, I guess, like you said, you factor in age and fertility and whether that's viable or not. But then at least people can have that informed decision to make, to decide what's right for them. And in regards to why does it often appeal to LGBTQIA plus singles, women, and people starting their fertility journey? Why do they always consistently consider that first?
Because it's in the media that IUI is the option. And I think going back years ago, when I first started doing IVF, and we're talking, in 2000, it was generally the way that most LGBTQ families decided to start their family. And they didn't do IVF, they did IUI. Because in those days, a lot of people did home insemination. So they would choose to either have a known sperm donor who was a friend, and they would self-inseminate at home. As the clinics became more mainstream and couples were more aware of the options of going to a clinic with the protections that come with that, I think it became more obvious to people that there was an alternative to IUI, that it didn't have to be IUI.
And let's move on to something a little bit different, another pathway that people can choose if they're from the queer community. And we're going to talk about IVF. People assume they know a lot about IVF, but can you give us a basic explanation of what IVF is and what those options are for LGBTQIA plus singles, couples, and other families?
So an assessment first to decide whether IVF is the right pathway. And the reason for that being that, for example, if someone was found to have a very, very low AMH level, she had a low egg reserve, then IVF has got a lower chance of working because we're not expecting to get many eggs. So we need to know that before we get started down that pathway. I think the other really important thing about IVF is, if we're talking about a couple, is are they thinking that they want to have shared motherhood or reciprocal IVF? So one partner provides the eggs and the other partner carries the pregnancy. And that is really attractive to a lot of our couples because they feel that there is a connection from both of them. One carries the genetic connection by providing the eggs, and the other one is the birth mother, and so feels that connection is there. And so more and more I'm seeing with couples that is the route they decide to go down. Whether they do that at the same time, so they have a synchronized cycle where the person donating the eggs is ready for egg collection when the person receiving the embryos is also prepared. That is, down to personal choice, really. I think in a lot of ways, freezing the embryos and then the person carrying the embryo comes back to have a frozen transfer is a slightly less stressful scenario because you can be sure that the embryos are in storage. You can be sure that the womb has been prepared appropriately, rather than having the pressure of you both needing to be ready at the same time. I think the other consideration there is that you can support each other differently if you're not both going through treatment at the same time. So the person who's having the egg recovery might feel a bit bloated, might feel a bit uncomfortable, might feel a bit emotional, might want their partner to be there supporting them, and then they can support their partner when they carry a pregnancy later on. So there's pros and cons to doing it at the same time. And I would say with my couples that I see, I'd say half of them decide that they are going to go down the route of shared motherhood, but not all of my couples decide that is what they want to do. And sometimes one of the first questions I say when I meet couples is, have you got any ideas of how you would like this pathway to look? Because sometimes they go, no way am I carrying a pregnancy. It's not for me. It's not what I want to do. So we've got to identify that right at the beginning.
And it's important, isn't it? Because you might identify like tocophobia, a fear of pregnancy, or just someone that says, actually, physically, I don't like the thought of being pregnant, or I've never had that feeling. And then actually some people do turn around and say, well, I don't know how I feel right now, but in future, I may want to carry a sibling. And I mean, talk a little bit about that, about the option for fertility preservation for the partner or both of them, or all involved.
Well, that's the other huge advantage to doing IVF compared to IUI, because with IUI, you have one shot at it each month. You don't have anything you can put in storage. Whereas with IVF, if the partner who's providing the eggs is someone who's got good egg reserve and the embryo quality is good, then those embryos can be put in the freezer and they can stay there, for several years while one partner then carries the pregnancy. And if in future they decide that the other partner also wants to carry, then you've got the embryos already made. So that is a huge attraction to doing IVF. In terms of leaving the embryos in storage, they can be there. They don't change in quality over time, even though the person who provided those eggs is getting older. The success rates remain what they were when we created the embryo. So that's a huge
Yeah.
attraction as well. The other thing that's really important when couples are trying to decide about who has treatment, it's not only the AMH, but it's the age. So if they both want to produce eggs, then of course the person who's older might want to think about going through their IVF sooner, because as they get older, their egg quality will naturally decline.
Yeah.
That's just a factor of biology. We can't change that. And so that's another question I always ask the couples is, have you decided who's going to carry, who's going to carry first, who's going to provide eggs first, so that we can then give appropriate guidance.
Yeah, and it's good sometimes to get both or all people involved tested first to actually determine, isn't it, whether or not, the older person is the least fertile or vice versa. Because, in our experience, I ended up being the least fertile and the youngest, and
Yes.
had secondary infertility. So it's a really great option, isn't it, to preserve fertility. Can you share with people what the differentials in cost is between either a usual IVF and reciprocal IVF or shared motherhood or parenthood? What does that look like for people? Because that can sometimes be a deciding factor where financial barriers come into play.
So essentially, we would go through a costing plan for individual couples, give them the information, because it really depends on what dose of medication they need,
Yeah.
etc. So shared motherhood is approximately £8,000 to £9,000, including the egg recovery for one partner, the embryo transfer for the other, and the medication costs. Of course, you've got to add into that the donor sperm. So that depends whether they're bringing donor sperm from somewhere else, whether they're purchasing it from TFP. Now, if they were doing an IVF cycle, they'd be looking at about £6,000 to £7,000 for the cycle itself. The medication costs again could be anywhere between sort of 1,200 and 2,000, depending on what their AMH is. And if they needed donor sperm, for general IVF as well, that adds to the cost. So there is a bit of a cost differential, but it's not huge. When you take into account, you've got two people having treatment, you've got the egg recovery and the embryo transfer.
And again, I think it is really important, as you said, to consider that those medication costs can fluctuate dependent on whether or not you're reacting well to them. If you need more stimulation, you need more support. So that can change. So it's really important for people to, have kind of an average cost in their mind, but know that that can change. Isn't that right?
Yes, and what we do for every single first consultation with one of our doctors is you're then provided with a costing plan afterwards, which is absolutely specific for you. It's not just a price list, general price list. So there it gives you what the cost of treatment is if you're doing standard IVF, if you're doing shared motherhood. It gives you your medication cost, because at that first consultation we know what the AMH is, so we can say, right, your AMH is normal, you'll be on a standard dose, or your AMH is very high, we're going to drop the dose, and so we can tell you what those costs are. There are some additional costs which include the infection screening, so that's hepatitis B, C, HIV blood tests, which are required before going through treatment. And then we also recommend, before anyone goes through an egg retrieval process, that we've done a chlamydia test for them. And before carrying a pregnancy, we do want to make sure that they're immune to German measles, which is rubella, and also check their thyroid function, because people who've got an under or overactive thyroid, which they may not know about, they may not have symptoms, but that can have implications when they're pregnant. So we always check that in advance.
And another option that people may need, that often people aren't aware of, is ICSI. Can you tell people a little bit more about what ICSI is, what it stands for, and why someone in our community may need it?
Okay, so ICSI, it stands for intracytoplasmic sperm injection, and it is a way of improving the chances of fertilization if the sperm results are not completely normal. So we have very clear guidelines that sperm needs to have a certain number of sperm, a certain motility, which is how well they swim, and not have a raised proportion of abnormal forms. And so if the sperm's completely normal, we do something called insemination, routine IVF insemination, which means putting each of the eggs in a dish. About 100,000 sperm go in the dish with the egg, and those are left overnight to their own devices, and the strongest sperm usually fertilizes the egg. So the following day, the lab will be able to see how many of the eggs are fertilized. If there is a situation where the sperm results are not optimal, and this might be that the donor sperm looks really good when it's frozen, but for some reason, when it's thawed, isn't as good as it should be, then we recommend doing ICSI. And then how the lab do that is they pick up an individual egg, they pick up an individual sperm, and they inject it into the outer portion of the egg. It cannot guarantee that eggs will fertilize, but it's increasing the odds that fertilization will occur. But more importantly, it's reducing the risk of a total failed fertilization. So there's nothing worse than going through IVF and finding the next day that your eggs haven't fertilized. That can happen with standard insemination. The risk of that is about 5 to 10%. The chance of having a complete failed fertilization with ICSI is less than 5%. So if we're worried about the sperm, we would recommend ICSI.
And that's really good because it then offers reassurance, doesn't it? Especially when using precious or limited donor samples, whereby the donor's retired, someone doesn't have access to any more further donor sperm, and they want to ensure that that child or any future children, are of the same other genetic parent or donor. So that's really important. So when it comes down to it, how do you choose what treatment is right for you, and how do TFP support LGBTQIA plus singles, couples, co-parenting or other family forms in starting that journey and what's right for them?
So I would say these are your options. I will put in my letter that I send to them what the statistics are for their success in their particular situation versus the cost in their situation. And then it really is ultimately, unless there's an obvious reason, for example, if the tubes are blocked, we would say, absolutely, you can't do IUI, you need to do IVF. But if there's a choice and they're 30 years old with open tubes and a normal AMH, and there's a choice to be made, that is their choice. I'm not going to push someone in one route or the other. I will give them the information to make that decision, but then it is down to them to decide.
Right, thank you. And that's the right thing, isn't it? To give people as much information as possible, all the evidence and statistics, so they can make an informed decision on what route is best for them.
Laura, we've talked about the different options for starting the fertility journey, whether that's IUI or IVF. Would you mind giving us your personal experience of the building your family and being part of the LGBTQIA plus community?
Yeah. I mean, my wife and I have been together 18 years, married 15. We had civil partnership. And then when marriage equality came in 05, we changed it. But when we started our journey, we knew that we wanted the opportunity to potentially one or more of us carry a pregnancy. My wife had severe PCOS, or quite high BMI, and was told by the NHS, you'll never carry a pregnancy to term at a very young age, back when there wasn't much evidence around PCOS and the implications of what it could do to pregnancies and birth. So she kind of had written it off. So me being, albeit 4 years younger, was like, I'm happy to carry, that'd be great. And when we finally looked for a clinic and found one that felt inclusive, felt safe, and they asked us lots of questions, how can we support you? What do you need? And when we had that conversation, they did say, there is a potential that we could get you pregnant, to my wife, with PCOS. It might take some time, depending on how severe it is. We'd need to investigate, but we can look at that. So for us, that kind of gave us the decision of, okay, she was older, I was albeit younger, let's move forward with her. So when we went through that experience, we couldn't afford IVF at the time. I would have probably preferred that. It would have been potentially quicker for her, especially, but financially it just wasn't viable, and we didn't have access to NHS funding. So we self-funded. We had to go through IUI, and she had 3 failed IUIs, and we got pregnant on the 4th, and we lost the baby at the end of the first trimester. And that was really difficult for her. So we took some time out, physically and psychologically, to just start again. And then on the 5th attempt, it was going to be our last attempt for her. She fell pregnant with our eldest, so she's now 11. And so fast forward a few years of no sleep, because our eldest never slept. And we decided to go again, but this time with myself. And my fertility was okay. It wasn't high for my age, but it was okay. And I had IUI, natural, unmedicated, 2 cycles. And I knew what the stats were. I didn't think I'd fall that pregnant that quickly, but I did. And I had our son, and he is now 7. And both being from big families, some people like holidays and handbags and nice trips, and for us it was a big family, was what we dreamt of. So fast forward again, a few years later, we decided to start again, and I really loved being pregnant, really enjoyed the experience, so was looking to do IUI again because I'd felt relatively quickly, and obviously had conversations with the consultant, said don't assume that just because you fell quickly the first time this is important for queer people to consider, and anyone, that it will happen again. And I made that assumption, bit silly really, and had 3 failed IUIs, and we didn't understand why it wasn't happening. I ate well, was healthy, looked after myself, exercised. And we had further investigative tests to find out that my ovarian reserve had halved in 2 years. Like, just no reason for it. And they couldn't find the reason. So that was quite difficult to grasp, that my fertility was just on a decline. And then we had to make a decision to move to IVF because we only had a certain amount of donor sperm left. And we wanted our children to all have the same donor or other genetic parent. So we looked to move to IVF, then the pandemic hit and it was the first lockdown. And so we got told, we'll do an egg collection, we'll preserve your fertility, which we were really happy about. And then a week later got a call, the world's gone into lockdown. All the clinics are closing, we can't collect your eggs, which was really difficult. So I was thinking, how long is my fertility going to hold up for? There was so much unknown around the pandemic. And then obviously there was multiple months that we had to wait. And when the clinics started opening up again, it was quite a strange experience. She couldn't go to any appointments. I was having COVID tests and all these tests beforehand to check that I could actually have treatment masked up going in. Really quite surreal. And moved through to have a fresh transfer for IVF. I only ended up getting 5 viable embryos in the end, and they weren't all of very good quality. I had 2 that were okay. And just out of sheer desperation, I think, at the time, and because of the situation we were in, we made a decision, which I feel, looking back now, was wrong, to put 2 embryos back, and they didn't work, and they were the best ones. So didn't work. It was really difficult. And then we made, that final decision of the next is probably going to be the last one we can afford to do for a while. And this was in between lockdowns. And I had the 5th attempt, which was a frozen transfer, and I fell pregnant. So we had our 3rd child, our daughter, and she's now 3, nearly 4. And that was a traumatic birth. It was really difficult. So I had spent time recovering from that. And we'd always had a conversation about 4. My number was 4. As a child, I always thought I wanted 4 kids. I was an only child. I had a half sister, but I desperately wanted more children. And we looked at that opportunity, and my wife said, how about baby number 4? And I said, I don't know. And she said, no, me carrying, because we had a conversation around, whilst it may not be important for us, but it might be potentially important for our eldest to have another full genetic sibling, and considered that, but also whilst extending our family. So we did all the things, all the supplements, saw the nutritionist, did all the things that we needed to do to ensure she was super healthy. And she fell pregnant first time, first round of IVF, which was amazing. And our youngest is now going to be 2 in a few months' time. So had an incredibly long journey, and it doesn't sound like that many cycles, but obviously when you're going through the hormones, the medication, the financial barriers, the systemic discrimination in the healthcare system and society, it's a difficult journey when you're queer or a female same-sex couple or whoever you are. But we're incredibly lucky that we got to that point, that we've finally created our family.
Thank you so much. That certainly is a very long journey that you've both had, you and your wife. I think what I would like to hope is that in time to come, we wouldn't actually have to have a conversation about whether people are getting the same treatment, whether they are heterosexual or whether they're from the LGBTQIA plus community. It should be that everyone is treated inclusively and everyone feels the same way. And I have seen a huge change from when I started doing IVF in 2000 to now. It really is different. We're not there yet. We have not got to the point where it is as inclusive as it should be, but I like to think it is steadily improving. But just in terms of the importance of you feeling seen and being heard and feeling supported, what did you find particularly helpful when you were going through treatment? Did you have access to counselling at your clinic? Did you have access to online support? What did you do?
Well, we had obviously the implications counselling, which I would say to everyone going through fertility treatment or considering it, it is one of the most important things that you need to really take time to digest, process, and if you need further sessions, do it, because it's needed, especially when you're going through the emotions of and psychological unpacking of being a non-biological or non-genetic parent, or whether you're the non-gestational mother or parent as well. It's really important because that comes with a lot of baggage, a lot of genetic loss. and can have an impact on you or all involved. And so we had access to that, but for us back then, there was no support. So when we created the organisation LGBT Mummies, it was because there was a lack of support in the community in safe spaces. But for us, it was really important to find a clinic that understood our needs, that knew they weren't maybe going to get it right all the time, but that had that good intent to really listen and give personalised care based on our needs. And the fact that they were supportive of the whole community, you know, whether you were a female same-sex couple, gay dads, trans, non-binary, gender non-conforming, whatever family unit you were from, they supported everyone. And for the queer community, that's really important. We don't want to access spaces that exclude any parts of the community. So for us, finding that safe space was really important. And
Sure.
finding your space for support is crucial, because you want to hear people's lived or living experience to say, what do I need to look out for? What might trigger me? What can be harmful? Or what's really useful? So finding that safe space or community is definitely important for people.
I think absolutely you've hit the nail on the head, and that's what a lot of people say to me is, I want to find a community that I can
Mm.
feel they have been through something before I'm going through it. They can give me advice, they can tell me what to look for. So I think that is hugely important. So for someone, perhaps if I had a patient tomorrow who was starting out on their journey and I signposted them towards you, what would you be doing for them as a first off when they meet you?
We have 13 online private support groups, so it'd be understanding who they are, what their identity is, what their journey is so far. Have they got children? Are they starting a new journey? And supporting them to decide what groups are right for them, providing guidance on the different pathways. But of course, for us, it's really important that we work with experts. So that's why we work with TFP. We work with trusted partners who are safe, inclusive, compassionate, and care and understand and are educated in who we are as a community. That's the most important thing, that we are signposting people to those safe spaces to start their journey, and then giving them those options, and they can make informed decisions on whether it's fertility treatment, whether it's adoption, fostering, or whether they're extending their family. What does that look like? And we signpost people to appropriate clinical or expert spaces where they can be supported further. And that's so important, that they are going to spaces where they know they're going to be safe, especially right now. Thank you so much for your time. And please, if you want to hear more about how TFP can support you in your journey or support you in future journeys, please reach out, give them a follow on their website. And Chantelle, if you can just close for me and just tell people where they can find you.
Thank you, Laura, and thank you for hosting this, because it's been really
Thank you.
valuable. And I think we do need to just all work collaboratively to raise the profile of what is available for the different communities. Essentially, what I would say is, if you're starting your journey and you're thinking you might want to go down the route of IUI or IVF, please do contact us, ask to book a first-time consultation with one of our team. That will include having your AMH tested. It'll be an ultrasound scan. If you're in a couple and you're absolutely certain that shared motherhood is something you do want to do, then we will offer both of you the AMH and the scan, so that we've got that information and can start the conversation straight away. If you're just exploring options and you're not sure who exactly is going to be the person who provides the eggs or carries the pregnancy, then one of you may choose to just have your AMH and scan done. We'll have the consultation. We can then add on to that if need be. But the starting point really is come and talk to us. We also do offer tours. So if you want to come and see the clinic, meet some of the staff before you make a final decision, get a feel for what the clinic's like, we can do that as well.
Right. Thank you so much for your time today, Chantelle. And thank you everyone for watching.
Thanks, Laura.